Welcome to the Assessing Cessation Coverage and Health Plans, Lessons Learned in Kansas and Missouri. All participants are in a listen-only mode, and you may ask questions at any time in the Q&A box on your screen. If you should need technical assistance, please send us a note in the Q&A box or email events@onesourceevents.com. This webcast is being recorded and will be available tomorrow and can be accessed using the link you used to register. And now we'll begin the webcast, and I'll turn it over to Ann DiGiulio at American Lung Association.
Thank you, Kayla. Welcome everyone today to today's webcast, Understanding the Coverage Landscape, a case study in assessing cessation coverage. Just a couple things to note, as Kayla mentioned, this is being recorded and will be available to watch again or to share with colleagues and other people that may not have been able to watch it. We are not planning on sharing the slides, as we'd really like you to rewatch it and really get the full experience. If you need specific questions, please feel free to reach out to the Lung Association team at cessationta@lung.org. Additionally, as also was mentioned, we do have a Q&A feature, so please feel free to use the chat box and ask us questions. We're going to have a really great, robust discussion at the end. And then the last thing I just want to mention is we've shared a number of documents in the document file with all of you, and they're also available on our website. These include the case study that we will be talking about today, as well as the assessment tool that both Kansas and Missouri used. And lastly, we have a glossary of healthcare terms that my colleague Ruth is going to talk about a little bit later. So thank you again so much for joining us. We're really excited that you're here. And with that, I'm going to turn it over to my colleague, Ruth Kenovi. Ruth.
Great. Thank you, Ann. So just wanted you all to know who's kind of speaking with you today. And so, as Ann said, my name is Ruth Kenovi. I work at the Lung Association and really spend some time on a cooperative agreement that we have with the CDC to help provide technical assistance to state health departments as well as other stakeholders, and really trying to do our best to improve cessation coverage throughout the country. And then we also have Michelle, who's going to speak in just a bit, but I wanted to introduce her as well. Michelle Paterino has worked in tobacco control for 20 years after 10 years learning the ropes at a regional health plan. In Colorado, she directed the state tobacco program's contract for healthcare provider engagement, which included individual provider guideline, education, and large health systems change grants, in addition to quitline sustainability. She's brought that expertise to several states since Colorado and ended its program, and worked with the CDC and the Lung Association on projects with a national focus. When she's not working on tobacco projects, Michelle also works with her state Medicaid agency and state health benefits exchange. So she has a wealth of knowledge. What I wanted to just kind of talk about is what we're going to talk about today. So we did the welcome. I'm going to provide a background on tobacco cessation coverage, just making sure that we're all kind of on the same page here, as well as talk briefly about the assessment tool that has been established. And then Michelle is going to speak to you about the case study and really facilitate a dialogue and discussion with people who've used this assessment tool from Kansas and Missouri. And I think it's going to be a robust and good conversation that we have today. So I might be speaking to the choir here, but just want to make sure that we're really on the same page. When we're talking about a comprehensive cessation benefit, we're talking about 7 medications, much of nicotine replacement therapies, as well as bupropion and varenicline, as well as 3 types of counseling: group, individual, and phone. So that's what we're talking about when we're talking about coverage, but we can't talk about coverage without also talking about barriers, right? So even if something is covered, if you can't access that, that's really a real impediment to getting the treatment that people need. And so there's a listing here on the screen, but things like cost sharing. Is this cost prohibitive? Are there limitations on how often someone can get treatment? How often in a lifetime, in a year? So these are all really important pieces that we're looking at, and important for the conversation that we're having today, as well as doing any work around this. And then, as always, we recognize that coverage can vary by state, payer, and plan. And so that will bring us to our next slide. And recognizing that this can be really complicated. I put this visual on here, not with any expectation that you all can really view it, but just an acknowledgement of how complicated some of this can be, right? Coverage requirements differ based on type of health coverage. Is it Medicare, standard Medicaid, Medicaid, private, Medicaid expansion, right? Private insurance, employer-based, or, oops, sorry, we got moved on our slides, so hopefully you can see that. And so each of those rows that have different colors represents a different type of insurance. And then we acknowledge that different types, like different plans within these different categorizations, can really vary. And that's also kind of looking at, those are things, types of insurance that are actually regulated. Then there's also like non-compliant plans that really are going to be outside of the purview of this conversation today, but just acknowledging that this can be a tricky landscape to navigate. So, I mean, the Lung Association just acknowledges that with most regulated plans, most of them have a comprehensive coverage, but there are variables in kind of what barriers exist. And so while we work to ensure that there is a comprehensive coverage benefit, we also kind of acknowledge that there are gaps, and we need to identify those gaps and help patients and providers navigate that as we work to fill them in. And so that's kind of where our tool that assesses coverage comes in. So this was released last summer, and the Lung Association worked with the CDC, Segway, where Michelle is representing, and a number of other organizations to establish a real guide on what do we look at, right? There's so many things that we can look at when we're trying to assess coverage in a state. And so we recognize that this tool is broad. It is 27 pages long, and it's there to be a comprehensive list of all the things that we can look at, but we strongly recommend that if someone's going to use this, this is not we use everything throughout this guide. It is really a menu, right? We strongly recommend that you make a smaller look at, all right, what data do we want and how do we plan to use it? And I think that's some of the conversation that we're going to be having today, is really focusing on that and how to use the tool in a way that's meaningful and helps you get the best data that you can possibly get. So we hope it's user-friendly, but we just acknowledge that we really want, there's some time and work that's necessary in kind of using this tool. And a little more. So we're going to be talking with Kansas and Missouri, who are kind of our pilot programs, really used it in different ways, but I think there's a lot of lessons that we learned from them that help people in the future kind of looking at how we can get the best data possible. I do want to plan, we're talking about, this is a big, it's a big tool. And so there's folks within the Lung Association, myself and Anne, as well as our colleague Reggie, who are available to help people kind of walk through this document so we can get a better sense of how to use it if you need some help. And I do want to just kind of flag that Anne mentioned the glossary that we have available. This came up, we were realizing that so many people in kind of our public health world have different lingo and words that we use that are different than what the insurance world really looks at. And so we put this glossary together so that we can really make sure that we're using the best lingo when we're talking to members from the insurance world and are using the same words so that we can communicate and know that we have the data that we need. So I think I kind of flew through that, but I hope that's just a quick overview of, the importance of a comprehensive benefit for tobacco cessation and what we're talking about there, but also a background on the cessation coverage tool, like assessing the tool assessing the coverage tool that we have available. I do have a quick polling, a poll that we have, so I would love if we could kind of press that out. We just love to get a sense from participants today to know, are you interested in assessing cessation coverage of health plans in your state? It'd be great to know where you all are at as we're having this conversation today. I'll give it another few seconds or so. Well, thank you all for your participation today in general, and please don't ever hesitate to contact Lung Association's staff with anything that you have around this issue, but I will pass it off to my colleague, Michelle Paterino from Segue Consulting.
Thank you, Ruth. It is always a pleasure for us to work with the Lung Association on these issue briefs and case studies. It's a real opportunity to take the tools and policies and recommendations and see how they really work in the real world. And so we're really happy to highlight the work of Missouri and Kansas. I met the folks there earlier this year and had some interviews, conversations with them, and worked on the case study so that we can present that to you today. I did want to say just a little bit, though, about the actual assessment tool. This case study is really meaningful for us because Segue Consulting, as Ann mentioned, did work on the assessment tool itself early on. And our input on the tool was really informed by work we did on another health plan assessment project. For several years in a row, we were scoring the responses from health plans on a really broad set of questions about prevention, chronic disease, the way they offered tools and reimbursement to their providers, their quality programs, and those kinds of things. And so it really was driven home for us and really clear that different types of health plans really do look different when you start getting down to those detail levels of them. So that first recommendation on the instructions that determine what kind of health plans you want to look at, it really does mean something from a health plan perspective. Self-funded plans are designed differently than fully insured plans, and a self-funded group plan is different if it's for a large group like state employees or county employees, those thousands and thousands of people, than for a smaller employer group. You also see that on the fully insured side of the group or of the business, where a plan for an individual does look different than a plan for an employer group. So as we really got familiar with those differences and understanding them, we recognized that just asking a coverage question to a health plan, in general, like saying, how do you cover tobacco cessation? That's really pretty meaningless for them because it varies so much. So the directions about picking what type of health plan you're interested in, that's really going to help you use the insurer's language. So like Ruth talked about the glossary and how important it is to be able to bridge the terminology gap, that's kind of what this exercise does when you figure out what kind of plans you want to look at. And then determining what questions you want to ask the plans. On Ruth's last slide, it showed the 5 different focus areas. There's the coverage area that talks about the different benefits. There's provider support, what kind of tools and training the providers might have. There's data and metrics, so we can look at the quality or what kind of improvements the plans are making with their populations. You have member support, again, that talks about what kind of programs are available to members and how they can interact with those. And then working with priority populations. So that's just a lot of questions there. Like Ruth said, it's 27 pages when you look at the whole tool. But if you are asking health plans to voluntarily participate with you and give you information about coverage, you really need to make it easy enough that they're willing to respond to you. So that's why it's so important to determine what questions you want to ask. And then the key partners and stakeholders is important. On the one hand, if you're making this a voluntary exercise with your health plans, you will potentially get better response and better engagement with them. If you work with a regulatory partner like the Division of Insurance or Medicaid, because they are in a different position and can tell the plans that they need to participate. If you don't have that option to work with a regulatory partner, it might make sense to try and engage with an employer coalition. Some states have a business group on health. And in that case, the ask to participate in the assessment is coming from the health plan's customers, which makes it, frankly, a little bit more important potentially than just hearing from the Department of Health. So that's the instruction there about identifying your key partners and stakeholders. So those comments and that kind of perspective are really embedded and woven into the directions and the how to use the assessment tool section. But again, we want to take that and translate this to real world experience for your benefit. I'm sure that's why you all signed on today, because those documents are already available to you. So let's go ahead and we're gonna jump right to the end of the story, looking at the success factors in Kansas and Missouri. You'll be able to read a little bit more detail about how each of them did the work and how they approached this, and then we'll have some conversation about it. But the success factors, the things that became evident as we were talking with the teams in Kansas and Missouri, good news for us is that these are really consistent with the instructions that we just talked about. The reasons we think that it worked in Kansas and Missouri so far as they piloted the tool with help from the Lung Association is that they selected a product line or a health plan type. In Kansas, they looked at their state employee health plan. So they were working with the State Employee Plan Council Oversight Group. In Missouri, they were talking with Medicaid MCOs, so worked with the Medicaid agency. So they sort of checked those first two items on the list. And then having a clear goal for the data and taking time to really focus on that data, that really made sure that they were using a reasonable size set of questions and could engage the health plans in actually getting answers. And in fact, they did, as we're going to hear a little bit more about. And so this is a background table, but I'm also going to just call it sort of a shortcut. When you look at the tool itself, I think this is really useful in helping you to get to those success factors and those instructions that we talked about being so important. For each of those coverage areas, and this one is, for each of the assessment areas, and this one is for coverage, this table walks you through why you might care about a particular type of question, what you might find out when you ask those questions, how you might follow up with plans or with regulators, or what kind of work that you might do. And then the last column is what information might inform you when you are at the beginning and trying to tailor questions and make them specific to your state. So I just wanted to give this as sort of one more plug on those things that we say will lead to your success. But obviously, like I said, I think the reason you all joined us today is to get to the panel and to hear from your peers. So here are the pictures of the folks that we're going to talk to. I'm going to ask each of them, I'll call on them to introduce themselves and then talk about a couple of the things that we think are important to start with. And while we're doing that, you all can enter your questions into the chat, and Anna and Ruth will sort those out so that we all can just start having a conversation and answering what you want to hear as we go forward. So I'm going to start with Elizabeth from Kansas. And Elizabeth, we believe that most of our audience is from state departments of health. So can you introduce yourself and talk about the role that the University of Kansas plays in tobacco cessation in your state?
You bet. Thank you so much, Michelle. Yeah, I'm Elizabeth Abla. I am at the University of Kansas School of Medicine. I am in Wichita, Kansas, and I'm a professor in the Department of Public Health, specifically population health. I became engaged in this after some of my colleagues had been engaged in this. One of my colleagues who is on the webinar today is Rick Kagan from NAMI, and he'll introduce himself and what NAMI is. But I was really lucky to be able to join Rick and his partner in crime for a lot of tobacco work, and that's Dr. Kimber Richter. And we've really been they are a force. They have accomplished a lot. I was lucky enough to be able to join them. So just briefly, from a perspective of being at a university, Dr. Richter and I have been able to approach different aspects of tobacco and cessation and treatment and prevention in maybe a slightly different way than Rick has approached this through NAMI. The advantage for us is that we have different grants. And so I have a grant through a funder, the Kansas Health Foundation, to work with work sites and figure out how do we help employers make it easier for people to not use tobacco at work and how to make it easier for them to quit. Whereas Rick and Dr. Richter really have been taking it from the perspective of the individual. How do we, especially with at places where there are substance abuse facilities, how do we assist these folks in successfully quitting tobacco? And we were able to join forces and talk about how we could together figure out strategies that are going to make the most sense. And really, when it came down to it, we needed to do a bit of a gap analysis, figure out what are the current policies in the state so that we could figure out what do we need to work on? How do we get that focus so that we're able to be strategic in our actions?
Thank you very much. And Rick, same question for you, because again, we're not talking to you from a state health department. So tell us about your organization and your role and how you participated.
So along with Elizabeth, we also have a separate avenue of funding from the Health Foundation, and along with 6 other organizations that's been ongoing since 2016, the focus of which is really to reduce the impact of tobacco use in the behavioral health community, and been a number of strategies and projects that we've been engaged in. I'm with the National Alliance on Mental Illness, the Kansas affiliate. And so as a patient advocacy organization, we're playing a unique role here compared to our university colleagues and our public health colleagues. But, I think it has been clear to us over the period of time that we've been involved that we needed to drive utilization of tobacco cessation benefits in various insurance plans. We needed to promote those benefits not only to patients, but primarily to providers. We needed to track the utilization of those benefits. And part of the aim of the assessment for us is kind of based on the success we had in 2018 with getting benefits in Medicaid substantially expanded to really unlimited counseling and year-round quit attempts supported by the pharmacy benefits and Medicaid. And part of the goal still is unrealized, and that is achieving that same level of benefits, more robust benefits in the state employee health plan, and also the private plans doing business in our insurance exchange. And because of the legislative process in our state, any expansion of benefits or any new mandate first has to be piloted through our state employee health plan. So therefore, we had a rationale for gathering data on the state employee health plan benefits. We learned a few things about about the benefit structure for tobacco, which I think makes it a little bit easier to approach policymakers, but still in all, they're very resistant to putting a mandate like that in place. But that really has been the driving force for us in kind of moving the assessment forward, and we're now ready to take on some of the larger private insurance companies. Now that we've completed the pilot and gotten some of the bugs out of the process, we're hoping to get some positive answers from private plans to engage with us on continuing the assessment process here.
Thank you, Rick. And so Valerie from Missouri is our first roundtable panelist who does work at a state tobacco program. So Valerie, can you introduce yourself and tell us a little bit about the tobacco program and why doing the health plan assessment was important for your goals?
Absolutely. Hello, my name is Valerie Howard, and I work with the Missouri Department of Health and Senior Services. I manage the Tobacco Prevention and Control Program, and we are the Centers for Disease Control and Prevention funded recipient to prevent and reduce tobacco use and exposure to secondhand smoke in the state. And we do that by working with a lot of partners to help us in our efforts. We can't do it by ourselves. And we've been working with our state Medicaid program, HealthNet, for a number of years. And in fact, quite a bit ago, worked together to increase the level of coverage for MoHealthNet members to have a comprehensive benefit package. And so we've been working with our MoHealthNet partner, like I said, for a number of years, and we're part of the 618 initiative, the Centers for Disease Control and Prevention and CMS, Centers for Medicaid Services, national project. And we've been fortunate to participate in that for the last 2 years. And that program, for those that don't know, works on the 6 most common and costly health conditions, and then the 18 evidence-based interventions to address those. And so our first round in that, we focused on stroke and tobacco. And as one of our activities to help us with the tobacco issue, we were looking at doing some kind of an assessment with our health plans. We have a very wonderful comprehensive benefit in Missouri for Medicaid members, but unfortunately, the data suggests that not very many are utilizing the benefit. So we wanted to be able to find out why. So tapping into a number of the other states who participated in 618 and developed their own health plan assessments through the years, we were painstakingly taking those states' assessments and trying to cherry pick the questions from their assessments to develop our own that would fit Missouri's needs when we found out about the ALA's health plan assessment. And so we were super excited about when it got finished, the ability to use that, because it really met the need of what we were trying to do for our work together, to give us a baseline of where are our health plans with what they're doing, their policies and their practices.
Thank you, Valerie. And Lori, our fourth panelist, also from Missouri, from the Medicaid agency there. Lori, can you tell us a little bit about your role in working with Valerie on 618 and using the health plan assessment?
Yes, thank you. My name is Lori Bushner, and I'm a registered nurse with the HealthNet, which is our state Medicaid agency. For fee-for-service side, which is our non-managed care recipients, but in the process of working on the 618 with Valerie, we have reached out to our managed care organizations to be able to look at assessment of what they're doing with our coverage, because at the moment, we have pharmacy benefits are actually carved out of our managed care. And we just recently carved the behavioral health cessation services into managed care. So we were looking at not only what they were doing to help with the tobacco cessation, but also how they were handling the new carve-in of the behavioral health services. So we've had a lot of back and forth, as Valerie said, trying to figure out the best assessment questions. And this one really did help us out. We were able to narrow it down to a specific amount of questions so that we weren't overwhelming our health plans. And with a little bit of a reminding, we did get them all 3 to respond. So we thought that was a very positive outcome of the survey.
Terrific. Thank you. So I actually love that each of our panelists is from a different agency or organization in their state. It really shows the importance of that partnership aspect. Rick, can you tell us a little bit about the additional stakeholders that were important in Kansas that you brought along?
Well, happy to. And, we have a lot of partners in our kind of broad scope of work that include certainly behavioral health and primary care providers in our state Department of Health and our Behavioral Health Agency and other patient advocacy organizations. When it kind of looking at the assessment that we've been involved with, our primary partners, along with the Lung Association, have been with Elizabeth, who's spoken, and Dr. Richter, both at the School of Medicine, University of Kansas. But we've been engaged with our Kansas Insurance Department along the way, just to see where they might plug in. They've been helpful in terms of helping to draw attention to existing tobacco cessation benefits and pushing information out through their communication channels. We've had a fair amount of engagement with legislators going back to 2018 with the expansion of benefits in Kansas Medicaid and revisiting with a new crop of legislators here in 2021 as we look at expanding benefits in private plans and the state employee health plans. I think we've yet to make any significant inroads with the private plans in terms of offering the assessment or getting their buy-in or consideration for what the kind of return on investment would be for expanded benefits in their plans. But we have that return on investment study. We have the data to back that up, and that certainly is going to be our next step. You mentioned the business group on health. We have the Kansas Business Group on Health here, which we've worked with. They've been helpful in terms of helping make connections with private companies, and I like the idea that you put out there that becomes really a kind of a rationale or a door opener with insurance companies as we begin to approach them. We've had good participation both from Kansas Medicaid and the state employee health plan in terms of getting access to data about utilization. So that's been an important partnership, and through an organization called the Kansas Health Insurance Information Service, we've been able to get utilization data on cessation benefits about the private plans doing business in the state. So I'll stop there, and certainly happy to address any questions. Thank you.
Thank you. And I will just remind everyone in the audience that you can type questions in if you would like our panelists to answer those. But Valerie, while Rick was talking a little bit about the data, access to data, can you tell us, I know in Missouri that you talked about some of the data that was important to your efforts too.
Absolutely. The data. Well, for those that don't know, Missouri, we're a part of Tobacco Nation, so we have a higher than national average use of adults smoking in the state, and within our Medicaid population, even higher, almost 3 times the national average at a little over 40%, and that's dropped from a year ago where it was 50%. So we have large percentage of folks in the state that are using tobacco, and like I said, particularly in the Medicaid population, and we have a very nice, comprehensive benefit package through our Medicaid program through MoHealthNet for cessation benefits for MoHealthNet members. There's essentially really no barriers to cessation services, but at the same time, less than 2% of the Medicaid members are actually utilizing the benefit. And so knowing high prevalence and small utilization, low utilization, we really needed to get a sense of why is that? And so the health plan assessment that ALA's put together was really helpful to us to get a better idea of really what is happening within the health plans in the way that they are letting members know about the service, about the benefit, and how they are working with their providers to get their patients connected to care.
Thank you. Okay, so we've talked about stakeholders that you might engage. We've talked about data. And Elizabeth, I just wanted to ask you quickly, because I know you brought up during our conversation some assets that you were able to bring to the table in Kansas to help get the assessment fielded too.
Yeah, you bet. Thank you, Michelle. So I'm really lucky to be able to work at the Department of Population Health at KU. We have medical students, we have Master of Science and Clinical Research students, and Master of Public Health students. And I've been really lucky to be able to recruit some fantastic Master of Public Health students to assist in this work. So some of the work, as I mentioned, that I do, it's around worksite wellness and how do we change the culture of the worksite? How do we change the physical and also the political, or as in policy type changes at a work site so that it's easier for employees to not use tobacco. So I've been really lucky. We were able to recruit a fantastic Master Public Health student who has been joining us on our team meetings. This is something that I would encourage the audience to consider. Who are some of those team members that are maybe the folks that you don't generally have at the table to do some of this work, but can align interests. So our Master Public Health students are required to do a capstone project, which is the equivalent of a thesis, but it is more practice-based. So we really want to align as many people as we can in their interest in helping to prevent and help people quit tobacco. So that we're able to be more powerful together. I love the win-win-wins. And if you haven't noticed this yet from Rick, he knows everyone and knows how to connect everyone to everyone. And so, that's a really powerful set of experiences to be around people who are very positive, who are making progress in this area, and to be able to feel like you're making a contribution. It's huge. So, I would encourage the audience to think about who are some of those maybe suspects that you don't usually have at the table, folks who could be helping to support your plan and putting it into place.
Thank you. Okay, we have a question from a viewer who asked about, do you know how many of your mental health agencies provide smoking cessation diagnosis and counseling? I'm betting that's a good question for you, Rick, in Kansas.
Well, not exactly. I don't think we exactly have the answer to that, but I think because of the work that we've been doing since 2016, it's coming more into focus. So we've been promoting something called the Kansas Tobacco Guideline for Behavioral Health Care, which we're more than happy to share with anyone. And this lays out some strategies for addressing tobacco cessation, not just in the behavioral health population, but among any patient population, frankly. And we've had an opportunity to offer some mini grants to about 14 organizations last year who demonstrated some work around implementing those guidelines initially. But I think the broader answer to the question lies in the data which we're still analyzing from a provider survey that we ran in 2020. And we should have some results from that in the near future, just to get an idea of how many of our respondents are engaged and kind of what's standing in the way. When we talk about barrier-free benefits for tobacco cessation, I think, we have essentially a barrier-free benefit structure in Kansas Medicaid, for example, but the barriers lie on the provider side in terms of their understanding, in terms of their competency to provide evidence-based treatment, and in terms of some of the the steps that they have to go through to successfully bill and get paid for providing the treatment.
Thank you, Rick. Lori or Valerie, do either of you have comments about that in Missouri?
Yeah, I'll just add that, similarly to what Rick described in Kansas, I mean, we have the MMWR that CDC released a year or so ago, but that data is based on 2016. And so at that point in Missouri, well over half, way more than half of our both mental health and substance use disorder treatment programs were screening and treating tobacco use and dependence among their population. We are getting ready to do another survey to see what the current rates are. But that's the status for us in the state.
Okay, terrific. Thank you. And just a further comment, it looks like, is that it seems that there's hesitancy from mental health providers and PCPs to take the lead on tobacco as a follow-up or to explain that question some more. So does anybody have any insight or suggestions about PCPs and behavioral health providers in particular, getting them engaged?
Well, if we're talking about what are we asking them to take the lead on? I mean, in the behavioral health community, I can speak as a part of it. I mean, we're part of the problem. I mean, we've initiated and sustained tobacco use among our patients for generations. So asking the culture change that's required in these organizations to kind of see tobacco as part of their treatment protocol, I think is enormous. So if we're talking about who's going to initiate some of this work, it may have to come a little bit from outside. We're, as a patient advocacy organization, we're a little bit on the sidelines, so we don't have the same vested interest that the providers do. If we're talking about the health assessment, I think maybe it may be different in other states, but it may be a state agency or a patient advocacy organization that has to take the lead on that as opposed to the direct care providers.
Thank you, Rick. So, Lori, I'm just going to ask you to make a comment as we start maybe winding down a little bit, but I think we've heard the comment, and it's also definitely, I think, obvious in the case study that these health plan assessments and learning about what benefits are covered from the plans themselves, it's just a piece of the puzzle. We've talked about making sure providers are trained and making sure that there's, Rick mentioned reimbursement, talk about some of those other things. Can you just, can you explain a little bit more about how that looks to you from your position in Missouri Medicaid? Is how is this health plan assessment just a piece of the puzzle now for you moving forward with it?
Sure. Well, like I had mentioned earlier, I work mostly with the fee-for-service side of our Medicaid. In Missouri, we actually do have a split population. So really doing the managed care assessment is only part of the puzzle for us to begin with, because we do have members that are not in a managed care organization. And so being able to take these assessments and look and see what kind of difficulties even the managed care plans are having with trying to get this utilization increased, it just makes it even more obvious to us on the fee-for-service side. There's going to be the same problems with our providers, and they don't have the extra layer of the managed care organizations to help them. So being able to look at that assessment and then take a look at what our primary care health homes, what we could do to assist them with our FQHCs, and even working with our Department of Mental Health to see what can we do for the behavioral health side of it. It's just learning about that and the reimbursements and what is possible and what's not possible. It has been a very big puzzle to try to put together, and Valerie and I still feel like we're only partway there.
Thank you. Valerie, do you have any comments on that same question?
Yeah, thanks, Michelle. Just to add to that, when we given the data that we have, I think we assumed that the answer was it's a lack of awareness by both the providers and the members as why the benefits weren't being utilized as high as as much as they are available. And to come into it with that assumption without validating that, we've learned that that's not necessarily the place to start. The other piece I will add, with the health plan assessment, that the tool that ALA has just released, it gets at the information around what are the policies and the practices, but it may not necessarily tell you why those things are being done or are not being done. And I think that's another piece that we've learned through the survey results is we know now their behaviors, but why? Are there barriers or challenges underneath that are contributing to the information that we receive through the assessment? So those are next steps for us in conversations with our health plans to find out, this is what you guys have said, but what kind of challenges are you experiencing as to why these look this way?
Terrific. Thank you. Elizabeth, how about any comments from you on the piece of the puzzle that this represents?
Thank you. I think that what is really hearing everyone talk right now, I'm really thoughtful about how this is an issue of equity, and it is a piece of the puzzle. It is a very large puzzle, but it is such an important piece because, we often think about this as, tobacco use as a quote unquote personal choice, when in fact it's really much more complex than that. And it's much more targeted in many ways than individuals choosing to use tobacco. And obviously there's an addiction that's associated with it. So when we think about the piece of this puzzle, when we look at a system that is as complex as healthcare and insurance and payment for services that we know are effective in treating tobacco addiction, we really need to be thoughtful about equity and ensuring that we are all exercising leadership in ways that are empowering, that are allowing us to have to make sure that we're addressing, especially those underserved populations who need the advocacy in the most dire circumstances. And I think we're there. We have so much work that needs to be done. And I think it's incredibly important that folks who are on this webinar today are feeling motivated and activated to be able to move, because there's so much work that needs to be done here.
Rick, do you have any comments before we turn it back over to Ruth?
I would just say, I think we've kind of touched on something here that is important, and that is, we may have decent or adequate or even excellent benefits in various insurance plans, but this concept of network adequacy, I think, is really kind of piece of the puzzle, and if we don't have providers who are familiar with the evidence-based treatment protocols, apart from the fact of, maybe they're not buying into it or they don't think it's important, but if they want to do it, but they don't know how to do it, they didn't get this training in social work school or medical school or nursing school. And so that's, all of these pieces are kind of joined together. And from an insurance company perspective, in a lot of situations, their job is to ensure that there are adequate number of physicians in certain areas of practice, or you can get a therapist if you need one for a mental health condition in different areas of the state. I don't think they've also recognized that having an adequate network of trained, competent tobacco specialist is something that they need to work on, and that's certainly on our agenda to get that across.
Thank you. Okay, Ruth, I'm going to turn this back over to you. I know you've got a couple of things to take care of before we wrap up.
Michelle, actually, you're going to turn it over to me. So this is Anne again. No worries.
Apologies.
So real quick, Kayla or Crystal, do you mind pushing out one last survey question, and really appreciate if everybody could take just a moment to answer that. And while you're doing that, I just want to thank again Michelle and Ruth for giving us the background, and Elizabeth and Rick and Valerie and Lori for sharing your experiences. It's been invaluable, and I'm incredibly grateful for that. And I'll just give it like another couple of seconds to fill out that question. And then I guess I'm actually going to the next slide. So I'll do that. A couple of quick, just last minute housekeeping things. If you've got any questions, or if you or your state is interested in working on an assessment of plans in your state and have some questions, or just want some help or some technical assistance, please email us at cessationta@lung.org. Myself, Ruth, and then our colleague Reggie are happy to help and kind of figure out and walk you through some of those kind of tough head scratcher questions. And so please, we are a resource. If you've got a question that's totally not related to assessing health coverage, that's fine too. Email us, we're happy to help. And then lastly, we're gonna conclude, and as soon as I'm done talking in about 30 seconds, and everybody's gonna be pushed to the post-webcast assessment. Please, please, please fill it out. And if you've got anything else that you'd like to hear topics on, please put that in order to continue to report to our funders on how we're doing. We really would ask for your help in filling that out. So we're going to end a few minutes early with the hopes that everybody has a chance to fill that assessment out. Again, it's very short. If you've got any questions, please feel free to reach out. And then hopefully you still have another minute before your next call. So again, thank you so much to everyone. And Crystal or Kayla, if you want to push us over to that assessment, that would be great. Thanks so much.